So yeah, hi, I'm Freya. I've been working at Wexham Park Emergency Department for 10 years. Actually worked my last day yesterday because I'm actually leaving and moving back to the Isle of Wight. So not because I hate the place, I love the department and they've been amazing to me, but actually I'm just moving geographically. So yes, this is to present my last year whilst I'm undergoing the trainee ACP fellowship. So just a little bit about what I've been up to in the last year. So like I said, I've been doing the job for 18 months. My department was willing to allow me to give it a go. And it was pushed by Karen Chivers, really, who's our practice development nurse, and my matron, Jo Hawkes, who was willing to allow it to just see what happened, really. So I'll tell you a little bit more about what I've been up to in that respect. I also completed my Masters in Advanced Clinical Practice, and I finished that in January of this year. Doing that was, I couldn't do my job without having done that. It includes both clinical, advanced history taking, and clinical skills of assessment, as well as looking at research, so it covers sort of a whole expanse of things. I think the most interesting part of it was doing my dissertation, and for that I did a service evaluation study, a qualitative study really, where I looked at my role and evaluated what the staff in my department thought of it, which was very interesting, and actually, that's a whole different presentation really, but overall the feelings and views of staff was really positive. Both from nurses and doctors, and actually I included specialty doctors as well, who I refer to. Knowledge was quite poor about my role, but people were really positive about allowing it to give a go. I had one consultant who was a little bit negative. Don't know who that is, which is a good thing probably, because I work alongside them, but I hope that maybe they'll change their mind, and there's possibly another study there to now evaluate it after 18 months to see if there's a change in opinion perhaps, but that's another study. So I've been doing this Health Education England Thames Valley fellowship. That's been, I'm going to go into a little bit more detail about what's provided for me, but a lot of it was about financial support. They financed me to undertake my non-medical prescribing. So I literally finished my MSc in January and I started my non-medical prescribing on the same day I handed in my dissertation. So it's been a busy year. So anyway, I finished that in August of this year and passed, so I'm very pleased I can now prescribe, and that is a massive part of my job. It now allows me to be what I class as an autonomous practitioner, because until I could do that, it was very frustrating having to go to a doctor every time to ask them to prescribe something for me, and it delayed treatment for patients, which, our patients can be very, very sick. They need treatment quickly. Sometimes they're in a lot of pain, and actually one of the biggest complaints in RED is about not receiving analgesia quickly enough, and that now means I can do that and give them better care. So, in regards to the fellowship itself, it's been amazing for lots of different reasons, and these are the main reasons. So being able to network with other trainee advanced clinical practitioners who are sitting over here, and trainee consultant nurses as well, from all different backgrounds. So other trainee ACPs that are paramedics, a trainee consultant nurse who's actually from military background, so again completely different and with a wealth of experience that they've been able to share with me. It's enabled, I think it will enable consistency in practice. So I think we're all from different backgrounds, and actually it ensures that we are all doing the similar thing across trust, which I think makes the role itself stronger. It's improved my knowledge. So we've had people from outside, experts in their fields, come and speak to us. We've had somebody talk to us about ECGs, because it's something I was very poor at, to people talking to us about the legal aspects of our job. So we've had a wide expanse of teaching. It's also, and this is probably the most important part for me, was the support I got from it. So I was doing this role in my emergency department on my own, and that for me is quite difficult. I'm used to being a nurse and part of a big team, and suddenly I'm practitioning and I'm doing it on my own in a completely new role that I'm making my own. But actually I had nobody to bounce off when I had a bad day or when I thought I was doing something wrong or worrying, and actually being able to come to this group once a month and offload my feelings. Sometimes there might have been a bit of a wobble, maybe some tears, but actually with colleagues who would listen and not judge me and would understand how I felt and tell me that they felt the same sometimes too. So for me, that was probably one of the most useful parts of it really. And obviously the quality improvement project, which I'm going to go into in a little bit more depth. So in regards to my clinical learning, I see all major presentations within the emergency department. I started off cherry picking a little bit, I'll be quite honest. I'd look and see what I thought I would see, be more comfortable with. But I soon learnt that actually when they're streamed as chest pain, actually they've got something completely different anyway. So it seemed easier to just take the next patient and actually go with it and try and learn from it. So I now see all patients that present to the emergency department, including priority call patients. Consultants are now allowing me to say, go ahead and take that priority call and give me a shout if you need me. So that feels really good, and it makes me feel like they're confident in me to go ahead and do that, and then they just keep an eye on me. I've also got an improved understanding of diagnostic tests. Part of this I did as part of my master's, but obviously as I go with each case, I look at the diagnostic tests surrounding this. We've also done a bit of case presentation as part of the fellowship and looked at a lot of the diagnostic tests around that. So I think that's improved. I undertook an ECG 2-day study session held by staff at Frimley Park Hospital. And again, this was very useful because it was something that I didn't feel like I was very good at. Yet actually, when someone shows you an ECG and someone's having an MI, if you miss it, you're in a little bit of trouble. So this was kind of really important for me. My confidence has improved and my decision making. And I've had a bit of feedback about that too, which is really nice. I've had consultants who've actually, who I haven't probably discussed a patient with for a couple of weeks. And I'll go to them and they'll say, wow, your confidence is really building. You're actually making decisions on your own and you know what to do with patients. So that feels really good. I have attended the fortnightly teaching with the Foundation Year 1 and 2 doctors. I was invited to join that right from the beginning. But more recently, actually, I was invited to join the registrar level teaching, which again is a real confidence boost that they actually think I might understand what's going on. A lot of it goes over my head, but it's definitely been interesting and good learning. Like I said, I've had some positive verbal feedback, but I've also had some written feedback from one of our medical registrar level doctors who said when she goes around with the consultants, a couple of the consultants had actually commented on my documentation and said, whose clerking is this? Because it's really good. And she pointed out that it was just me. So that was really nice. So she actually wrote that down for me, so that's quite nice for my portfolio. And obviously I've been trying to complete the RChem competencies. I think it was mentioned, but we've got the Advanced Clinical Practitioner curriculum that's set out by the Royal College of Emergency Medicine. And I've been trying to attempt to undertake the competencies. Obviously with all my studying, it's been quite difficult to try and balance this and get these done. And I also find it quite difficult when I discuss patients with a doctor to then say, oh, can we now do a case-based discussion on this patient? My fear is that they will then think, oh God, every time we discuss a patient, she's going to come and ask me to do another feedback form. So I must admit that is something that I found a bit more difficult, but I have been progressing through them and getting there steadily. So in regards to my quality improvement project, I chose to look at the improvement to improve the management of patients with suspected sepsis. I'm sure you all know this is a real hot topic, and it was something that we weren't doing very well. And I'll show you from the statistics in a minute. So there are 3 sequins. This is the Commissioning for Quality targets that are set, and it's a financial incentive basically to meet these. It provides the hospital with money if we actually meet them, but obviously that's not the most important part of it. So it's actually about improving patient care, and we know that the reason these are brought in is to improve quality of care for patients. So the first one is looking at screening, so ensuring the patients are screened when they come into the emergency department. And unless you screen them, you're not going to be able to treat them because you'll miss it. So screening initially, and then antibiotics must be given within an hour for patients with sepsis markers. And they also must be given within an hour to suspected neutropenic sepsis patients. So they are the 3 markers. So just a little bit of background. So the reason sepsis is such a big thing is because the UK mortality rate is at 30%, which is 5 times higher than that for ST elevation, myocardial infarction, and stroke. So it really is a big, big problem and responsible for 44,000 deaths a year just in the UK alone. 11,000 of these are thought to be preventable, and preventable by doing the things that I've just mentioned, which is giving antibiotics within an hour, and the only way we do that is by screening them in the first place. So international guidelines recommend the first hour antibiotics, and this is recommended by NICE. And the reason for this is because with every hour that antibiotics are delayed, there's an increase in mortality by 8%, which is actually a lot. So if you imagine 12 hours of delay, your patient's going to be really poorly, or perhaps, even worse. So the overall aim was to improve the recognition of patients with sepsis, to manage these patients in accordance with the national guidelines, with the overall aim to improve outcome. So the methods of doing this. So firstly, we had to collect pre-project data. This was just done by audits, and the audits that are provided by the sequence themselves. So we didn't have to actually develop a tool. I then went ahead and developed and implemented a screening tool. Now, I got this from the Royal College of Emergency Medicine and from UK Sepsis. And what I did was I pretty much copied it, but added some tick boxes so that the nurses, they like tick boxes. They can work their way through this lovely flow chart and tick the boxes, and it directs them in how to best manage these patients. We also implemented Sepsis Boxes. Now, these boxes were designed to try and speed up the process. So they include the really important things that you need for these patients quickly so that they can be grabbed and you can get out exactly what you need. So just antibiotics, fluids. I'm going to have to rush. So the screening tool had to be adapted based upon findings that we found, and processes had to be improved to improve efficiency, really, which was a lot about teaching, especially to reception staff, and making sure that they highlighted these patients when the patient walked through the door at the very beginning. So we also have monthly meetings for both sepsis and for the oncology-related patients, and then we try to improve things from there. And I undertook some root cause analysis, just looking at the data for each month to try and work out where the problems were occurring, where are the delays, why are we missing certain patients that we're missing, and what's the cause of this, and obviously then take some action according to that. So let's just look at this because this is a little bit clearer. But so in regards to the statistics, this was obviously at the very beginning. So in regards to screening, we were down at 20%. 1 hour for antibiotics, we were at 50, and the neutropenic sepsis patients we weren't even screening, so we weren't doing anything with at all. So this is when I put the tool into place. So as you can see, rapid increase and everything was great, and I thought, woohoo, we've cracked it. And then it all went a bit wrong. As things do, and that kind of shocked me a little bit. But actually, this could be possibly around the same time that we have new doctors in August, because actually, clearly, the screening continued to rise, and that's the bit the nurses do. I hope you can see clearly. That's the bit the nurses do. Yet, possibly when we got new doctors, everything dropped a little bit. So anyway, I did some teaching. I put up a big presentation, especially in regards to the neutropenic sepsis patients, and then we saw a nice big rise again. And things have continued to increase since. And actually, this only goes up to June because I did my year from June to June because we're always a couple of months behind. But actually, our statistics are even better. And the really good news is that for September, we actually hit 100% for patients with neutropenic sepsis. But not only 100% is that we treated all the correct patients that were neutropenic, but we also didn't overtreat either. So we used our point of care, which is where we do a full blood count immediately. And for those patients who weren't neutropenic, we didn't treat. So it also shows that we're not overtreating with antibiotics, which I don't know if you know any microbiologists, but they jump up and down when they start panicking that we're now treating everybody with antibiotics. So that's really pleasing. So overall success, I'll be very quick. Work still needed to be done, and at the moment we want to make a completely separate neutropenic sepsis pathway because actually nurses still get a bit confused about the parameters and the vital obs being normal in these patients because their bodies don't react in the same way. So we want to make a completely separate pathway, which is in progress. NICE guidance has changed just this year, so we want to adapt the tool slightly, but actually for adults it hasn't changed greatly. And other future developments are just premix antibiotics, which we've just brought in. We've got both tazocin and amoxicillin have just come in as premix, so to see if that speeds up the process. Sepsis trolleys, because nurses like trolleys rather than boxes, and they're right there. So again, just to make things quicker. Pre-written prescriptions, so the oncologist will already have written a prescription so that when a patient comes in, if they're a cancer patient, they will already have one, so we can just give it. And PGDs, this is patient group directive, so it means nurses can prescribe specific drugs. Again, microbiologists jump up and down a little bit about this, but it's working in other hospitals, so we're just looking through their guidance and seeing if we can make it work for us. And improvement in the use of point of care, because if we can do point of care full blood counts, we can make sure we're not over-treating, but we're treating the right people. So that's our future. So yeah, that's just summary, really. I'm sure you can read that anywhere.
Good afternoon. Right, I'm here today to talk to you as an ACP Fellow with Health Education England, and I'm going to talk, I'm not going to reiterate what Freya said because she said it very eloquently about our clinical journeys, and I would echo most of that with Freya. I'd say that the differences in my journey is that when we first started this, I believe that I work for a trust that doesn't operate an A&E, and that I could probably get the RChem part of the competencies covered in our medical units under doctors there. It became very evident after we started the fellowship that an A&E placement is essential for the clinical development required by RChem. So I had a delay starting in that placement. Very kindly, consultants over the Royal Berks, following networking with my ACP other fellows, offered me a place in which I started late in July 2016. So I've been there a few months, and that's one shift a week and 40 plus patients seen so far under the auspicious sort of supervision of their consultancy team there. So it's been massively beneficial to my individual clinical development with regards to working up sort of majors patients, either through to discharge or through to admission to the greater hospital at large, and my understanding and application of point of care blood testing and laboratory testing, and the extrapolation of that to the patient presentation. Something that, as a paramedic from a paramedic background, isn't really part of our required remit to practice pre-hospitally, because we don't have access to those biomedical tests. So that's been one of my steepest learning curves. With regards to the RChem competencies, I've seen patients covering most of them: abdominal pain, chest pain, breathlessness. Thankfully, spelling isn't part of the RChem competency. Falls, mental health, headache and palpitations. And two that are outstanding are wound assessment and cough management, but I practice as a minor injuries practitioner, and that's something I do day to day. It's a case of it's something I have expertise in. I now need to prove it to get the RChem competencies covered. So that's pretty much it. That's all I'm going to say about that. I'll get on to the project so we can recover some time. So as an ACP fellow working in minor injuries units, this is not a hashtag. It means fracture. It's a Torres fracture. It's a paediatric presentation of fracture when they fall onto an outstretched hand, which children often do because of the cortex or the makeup of paediatric bones, 2/3 rubber, 1/3 mineral, exact juxtaopposite of an 80-year-old person. They tend to bulge and bend and kink rather than break, and that's what a Torres fracture is, a bulge in the cortex of the bone. I initially took my inspiration from research that had been done by Vardy and others out of Glasgow Royal Infirmary to redesign fracture pathways so that they weren't funneled through this pretty much people are bent to NHS systems because we've always done it this way. They're seen immediately at the point of first contact with the NHS. They then go to a secondary clinic, maybe a tertiary clinic, when actually definitive care can be given at the point of first contact and they can be safely discharged. Now, Vardy and colleagues eloquently demonstrated this out of the Glasgow Royal Infirmary over a 5-year quality improvement that revolutionised delivery of fracture care in Scotland. And I took inspiration from this, and that's where the inspiration came from. The initial proposal was to manage a range of stable fractures in MIUs across Oxfordshire that present and do that as part of a health improvement project. So this project was presented as a collaboration between our specialist secondary clinics at Oxford University Hospitals and ourselves at Oxford Health Foundation Trust. The initial contact was made with those OUH stakeholders, those being trauma specialist doctors, and I said, I want to take work away from you. Okay, MIU is not physician-led. We had to have those stakeholder investment and backing for it to go ahead, or otherwise it was a dead duck in the water. And I thought it was going to be the hardest sell. Actually, it was the easiest part of the entire project. They were massively on board with it from day one. That they did point out how ambitious my desire to do about 8 different fractures was. So we scaled it down a little bit, and we decided that it would be a good management system. We'd do it with leaflet-supported discharge, and it would be a phased implementation. And the first fracture that we chose in consultation with our trauma specialist colleagues was the Torres Fracture of the wrist in paediatrics. Okay, so moving on, what we did. The primary aim then was to change management from a referral to a secondary clinic to primary treatment at the point of first contact, and then leaflet-supported discharge, therefore making it a C-treat and discharge with no other follow-up. The secondary aim was, if we could in the year, to launch other fracture pathways in a similar vein for different fractures, both in either children or adults, ones that I'd originally tabled. So what we did, the method was we did the pitch to HETV. That's how I ended up getting onto the fellowship. We had to say what our idea for health improvement was. The OUH stakeholders who got on board, and our own stakeholders. We were going to change, very much transform how we manage these patients in a very transactional environment, where waiting times have to be fulfilled, patient safety has to be either improved but certainly not compromised, and that subsequently led to actually the hardest sell was to my own organisation, where we ended up tailoring or authoring quite a big business plan. And I had we took a very shared leadership approach from one of my colleagues, Ange, who's in the room, we've divvied this up and put this through really as a team of 2. The business plan was submitted to our financial director, and we finally got consent after several redrafts. So we were coached there with what we needed with regards to the CCG requirements, etc., to make it a viable project. We went on to procurement of equipment. That took place in February 2016 from a start time when I first delivered the plan to HETV in September. We then did a lot of e-training with our practitioners, telling them about how the pathway was going to change and how they were going to operate it, and also some decision tree algorithms that they could work to, which you can see. You'll see an example here. It might not be clear, but it is up on the poster. We operated a traffic light system so that they could follow the pathways on who needed referring and who was safe to treat on this C-treat and discharge pathway. We then launched in April 2016, and then we went on to a 5-month quality assurance follow-up process. So patients were asked when they were seen in clinic, would they be amenable to being contacted by telephone? We could ask them questions about their experience on the pathway, so that we could make sure that we'd hit all the benchmarks with regards to what the patient needed for their care. That's what our practitioner algorithms look like. So we've got a common blue pathway, then you hit X-ray, you've either got a Torres fracture or you've got something else. So the green pathway, yes, you've got a Torres fracture, you go through to treatment with a prefabricated splint as opposed to old-fashioned plaster of Paris. The orange pathway is something that you refer cold to a second clinic. We do that electronically, and they go into a traditional plaster of Paris back slab. So they're the other types of paediatric fracture, Salter-Harris, which are fractures around the growth plate in children where their bones elongate from over years. And then the red ones are the serious displaced fractures that people get where a joint is interrupted or something like that needs an immediate live conversation with the trauma specialist where they view our x-rays. So that's what that means. These are the results. So over 5 months, we saw 67 kids in total. 44 of those were males, 23 females. We managed to follow up 51 of those by telephone. So we had a real good hit rate. If you know about kind of postal research and telephone research, they lose at least a third usually. And we found that we got better figures than that. People were only too happy to sort of talk about their experience really with this to help us improve. So we lost 16 to follow up. We had 3 attendances. They activated effectively our safety net within our leaflet literature to come back and see us. But on digging deeper, only 3 of those were, out of the 3, only 1 of those was for a clinical concern, which was uncontrolled pain. And 2 of those was because they were concerned that the splint smelt a bit. Well, all 3 of those patients had their, and I must say the one that was for a clinical concern was a patient from a fractured family, and the parent that brought them back was not the parent that was seen at the first initial consultation for treatment. So all 3 were treated with were advice only. They didn't need to go on, but that's what the patient numbers tell us. Our telephone audit was aimed around 6 key areas. The satisfaction with treatment at the time of being seen, and we had 100% affirmation that the treatment was excellent. Satisfied with the overall content of the discharge leaflet was a 94%. Satisfied with the guide in the leaflet to the requirements, to the child's requirements on analgesia, which was a 96% hit rate. Satisfied with understanding of how they activate the safety net was again a 98% understanding. The convenience was rated 100%. We had parents of multiple children who had experienced this, and you'll see from some of the qualitative comments on my poster that they were only too happy not to go to a secondary clinic and take at least half a day off work and all those, and childcare and all those things that represents. We asked, would you have preferred to see a doctor who specialises in bone injuries? And we had one patient's parents say they would have preferred that. So we get a figure for 98 rather than 100% because we just about picked up 50 patients. So that's where we are on the sort of cold, hard yes and no answers. We did also tease out, we had a free text box and we said, would you like to say anything else about the pathway? And those sort of more qualitative themes were then labelled together, and you can see that in the comments box on my poster, which is middle room over there. What we identified was that they liked that this didn't impact on the parents liked it didn't impact on their working life, and that it didn't re-impact on their children's school life through going to secondary clinics. They really, really liked that. They liked the fact that the prefabricated materials we used to treat this injury could be removed so that the child could stay clean, even the stinky boys. Which some of the parents said, my older child really smells at the best of times, and I wouldn't want him wearing a sort of cast for 6 weeks that he couldn't remove. But sometimes it's harsh to be a parent. So overall, really good result. What was the multi-organisational impact? This was a project that needed buy-in from another sister organisation, an independent foundation trust. Help generate dialogue between us as organisations, as us as the referrers and the OUH as the clinical specialty, and enhance that joint working relationship, so much so that the multidisciplinary ramifications were that we consequently ended up with a partnership project with not only ourselves, Oxford Health from the minor injury setting, but the OUH's own emergency department and the trauma specialties working together to implement these pathways across the board in both organisations. And I'm very pleased to say that the impact then on patient delivery is that the project was to enhance patient care and streamline the systems of work. We achieved this with this one fracture. We know we've got high levels of patient satisfaction on that one fracture from what we did with the telephone follow-up. Initial cost saving we demonstrated was in those patients we treated, that's a £5,500 cut in NHS costs just from the secondary referral costs of the clinics. You can extrapolate that's about £12,500 a year on what we just see, let alone what the OUH refer in with the buccal fractures. More difficult to quantify is the global saving to the wider economy, parents taking less time off work, missed school days, this sort of thing. And then of November this year, because of the enhanced working partnership, we launched another 8 see, treat and discharge pathways for both adults and children. They've been running for about 2 weeks. And with the figures that we have on just this 2-week period, if we extrapolate that out to a year, that's going to be over £60,000 of savings to secondary clinic referral in the NHS in total. And these are all fractures that can be safely treated at the point of first contact. This is me. My impact professionally is that with thanks to Health Education England, I am now well into a master's degree that I wouldn't have been able to pay for as a humble paramedic practitioner and with a young family. And their support has been phenomenal, and I'd echo Freya's what Freya said about having the support of my fellows on the project to sound off on, really, and with about trials and tribulations of being on demands on our time. I developed some leadership skills. I've had to within a shared process with my colleague Ange across my organisation. It's widened the professional role as a paramedic. We don't just drive ambulances. You know, I work in a clinic and I have done for a few years, but that's what a lot of people's view is of us, is that we're the people that call when you dial 999, but we work across different remits. And thank you. Last but not least, this led to me getting a promotion to an actual official title of clinical lead in my organisation for the development of pathways. I support any questions. Thank you.
Afternoon, I'm Spencer. I'm a specialist paramedic and a trainee advanced clinical practitioner thanks to Health Education England. That's me on the front there, and that's Jill, one of the OTs who helped me in my quality improvement project. And actually, the more I look at this photo, I don't like it. It's a PR mock-up in a car we didn't use outside a hospital we tried to avoid going to. But it was good for the magazine that it was in, I guess. I've had a great year, and thanks to Health Education England, I was on a path where the only route for me really was managerial, and the fellowships allowed me to stay clinical. Their backfill has allowed me to do a quality improvement project that I've been dying to do for many, many years, and they've managed to support me through a master's degree. And Karen will be pleased to know we're doing leadership as well at the moment, Lee and I. So the quality improvement project was a bespoke blue lit response of myself as a specialist paramedic and an occupational therapist, and we replaced the normal ambulance response to those older adults over 65 that had fallen at home. So we would see them as they'd fallen. There would be no delay or retrospective referral. We would see them as they made the 999 call. Our plan was, with my clinical assessment and their OT input, we could hopefully keep them at home, away from hospital, and prevent any further falls from falls prevention advice. And we carried a car, or van it was in the end, full of equipment that we could distribute to them on scene. The drivers for me really were admission in the older patient is thought to cause disorientation, delirium, risk of further falls, and deconditioning of muscles. I think the 10 days in hospital is equivalent to 10 years of muscle wastage in those over 80. People that fall over 65 are likely to fall again within 24 hours, and our local referral service is not very quick, and I think it's because they're as busy as all of us, but the falls service locally probably don't get to these patients for a week, whereas we're seeing them within an hour of them falling. And latest trauma data tells us that the demographics have shift to our older patients. I think they equate an older patient that's fallen to being hit by a car at 30 miles an hour. And these are the people that are being seen in EDs now. There are some more political secondary drivers. The government are really interested in ways of trying to avoid the admission of the frail and elderly population. Most importantly, for me, the patients and their carers prefer treatment at home. And I've seen a real shift since my time in the ambulance service when I first joined, that families wanted their relatives to go to hospital, and actually now they're trying to find ways to keep them at home. We saw 220 patients. That was in 50 days, so we did every Saturday for a year, and 150 of those we managed to keep at home. And that was an improvement on the normal ambulance response by 15.6%. There is a cost saving as well. The response of us going instead of an ambulance is negligible. There's not much in it. But I try to, and this is really difficult to nail down costs of what we've saved. But just looking at purely an A&E admission, we could have saved 93,000 just in 50 days. If we took that up to 7 days a week, it's something like £700,000 a year. And if you take off our costs, it's probably 300,000 that we're saving the NHS, which is 3 A&E consultants, 10 nurses, It's a lot of money. These are the areas where we just can't quantify the amount we save. So the input of the occupational therapist on scene. So if we're preventing other falls, we're preventing other ambulance, other healthcare input, surgery, physiotherapy, and hospital stays. And it's unquantifiable. One of the other benefits we found when we were on scene with the OT, she was able to phone her colleague at A&E if we were sending somebody in, and to report to them what she'd seen at home, and that would expedite the patient journey back home again. So there was another cost saving there. There was some good response. The patient feedback, there was a problem with SCAS, so I offloaded it to the OTs, and they did a really good job with a very short time, and we had about 50 responses back, and it was all fairly positive. And if I ever do the project again, I'll know that actually feedback is really important and to start it earlier. I left it too late, I think. There were problems along the way. I knew about long lies and acute kidney injuries. The ambulance service don't. It's not taught. And so to rectify that, I spent hour-long sessions in team meetings teaching colleagues within the ambulance service about long lies and acute kidney injuries. I can remember when I first started, if you pick somebody up and they could walk, then you would go. That was it. If they didn't have a broken bone or chest pain, that was it. You'd left. And there was no consideration given to kidney injury and long lies. There is a major problem at the moment. The ambulance service is so busy that our older patients that have fallen, who are not hurt, will actually wait many hours. I've seen horror stories of 14 hours waiting on the floor to be picked up. I've highlighted it to the ambulance service, so they do know it's a problem, and we are forming local focus groups to see how we can resolve this. I don't have a solution to it at the moment. Obviously somebody with chest pain or somebody seizing will take priority over somebody on the floor who's awake and talking. There is something going on in Hampshire at the moment where they're using some of the fire service responders to pick up our older patients. I like this because it means they get off the floor quicker. It worries me about the clinical side. Our older patients, because of their different disease profile, often don't present as severely unwell, and there's some subtle differences that I think they may not pick up, but we're keeping it monitored. There's a misconception by some of our older patients that actually ringing an ambulance means automatic admission to hospital, so they will delay calling us, so it actually generates an automatic admission for the length of time they're on the floor. There's also a delay in some patients where they don't have access or they've fallen away from the phone, and we were very kindly given pendant alarms by a local company that we were able to give out. So we were able to leave pendant alarms so they could access care or the ambulance if they'd fallen again. In doing this project, it's given me great links with the local geriatric consultants at the Royal Berks and the teams there. I've managed to present at local BGS meetings, and I've had a blog on the British Geriatric Society's website. And I still keep in touch with all these, and it's been a great link. We are reviewing the data at the moment. It is being represented to the CCGs. The CCGs were very helpful in the initial stages. They back-funded the OT release from the Royal Berks. They were very keen because it does meet high-impact interventions of NHS England. And we're currently looking at taking it back on over Christmas for a 3-day period, so it'll be Friday, Saturday, Sunday. Much like Lee, I've had a clinical placement as well, which I've learned lots as well, and it's been at the Royal Berks A&E, and I've had to go in and ask. I'm the first ACP ever to be there. They've never had one there before. And it's purely that we need to fulfil this RChem portfolio, which you can only do in an A&E department, which we didn't find out until we started. So this is my previous role. There would be a sick patient. I wouldn't know what was wrong with him. I'd take them to A&E. Somebody would find out what was wrong. A very clever doctor, I expect. And that's how I understood it. My new reality is that somebody else brings them in. I have to try and work out what's wrong with him. And this is whilst being chased around the department by a consultant or a sister saying that you've got an hour and a half left. What are you doing with them? But it has opened my eyes. It's definitely improved my clinical knowledge of disease and its presentation. I understand the diagnostics now. and the scan and begging at the radiologist's door, and improve my skill sets. Mark, who was here earlier, done an NIV course, which was really good for me recently, and TILS, PILS, ILS and ALS. And actually it works. I'm the first one in there, and Dave Clark, who's been very supportive. We actually have Lee, and we've got, I think, somebody else coming now, so there will be 3 ACPs there. Thank you very much.
Thank you. Amazing. Real variety of projects there, but all absolutely patient focused and making a difference. Questions? Yes, Gillian.
I'd like to ask Spencer if you've been invited at all by Oxford Brookes to talk to their undergraduate paramedic students.
I haven't, no, I haven't.
But would you like to? Because I probably could sort that out. I just think it would be so valuable for them to learn from what you've learned.
Yeah, absolutely, thank you.
Yeah. Yes, Gwen.
I'd like to ask Freya, your new job, is it an ACP? I mean, is this transferable to a new job? That's my question.
Yes, absolutely. So my new job is, not exactly sure, but it's 20% in the emergency department, and actually the rest of it is out in the community, keeping people at home. So a lot of what people have been talking about, which is they've got a very integrated system down there where they are trying to keep people out, rather than allowing them to come in, people with chronic diseases that actually
That's wonderful. My life at home life.
Yeah, absolutely. So the plan is that I will go in and assess people exactly like I do in my emergency department, but in their own homes, and try to treat them at home. And my prescribing will help with that, because it means I can.
But they've employed you because you've done this programme. How funny?
I think it's
That's what
probably
I'm trying
helped.
to.
Yeah, I think it's probably helped, because I think the other 2 people doing it haven't got as far as this yet. So yeah, I think they're hoping that I can bring something. Yeah.
Thank you.
Have a question?
Well done.
Yes.
It's to all of you actually, which is if there's a sort of one person in your organisation that you could have a conversation with about extending the project, the roles that you have, do you know who that person might be?
Yeah, we've already had that conversation, it's just a funding thing at the moment.
Okay, so then I can have another conversation with you afterwards.
Yes, we would love to extend this programme.
Yeah.
I think that the benefits are obvious, aren't they? They truly are. What you reap from this is far more than about one person. It's about whole service, isn't it? And it's explaining the benefits to the people who hold the purse strings quite often. And if we can just get that nailed, we'd be fine. Great. Okay. Any more questions? Right, I think you deserve a coffee then in that case. 10-minute coffee break.